Okay, well, good morning, everyone. My name is Dr. Stormy Monks, and I'd like to welcome you to today's Grand Rounds presentation hosted by the Southwest Center for Pediatric Environmental Health. So the Southwest Center for Pediatric Environmental Health is one of 10 pediatric environmental health specialty units, also known as PACUs, in the United States. And the purpose of each of these PACUs is to serve as a leading national source of medical information and consultative advice on environmental conditions that affect children. To serve as part of our mission, we offer this Grand Round series once a month. It's typically held on the third Thursday of the month, with obviously this month being a little different. Today, we are grateful for Dr. Jesus Diaz joining us. He will be talking about radiological exposure in children. But before we go on, I just want to make sure that there's a few housekeeping items that are addressed. You will not be able to speak during the presentation, but please feel free to add notes into the chat box. And at the end of the presentation, we'll make sure that Dr. Diaz is able to address those. I want to acknowledge the American Academy of Pediatrics, the CDC, Agency for Toxic Substances and Disease Registry, as well as the Environmental Protection Agency. Without these three organizations, the PACU would not exist. I want to let you all know that this presentation does qualify for CNE and CME. And so if you are interested in receiving that, please ensure that you follow the directions listed for these activities. Today's code activity, or activity code, I'm sorry, is 3488. And I can get this information to you as well. I'll put it in the chat. Our next Grand Rounds is going to be held on November 16th at 11 a.m. Mountain Time, where Dr. Smelsky is going to be discussing snake bites in children. You can use this QR code to register, and I will also put this registration link into the chat box. So without further ado, I want to welcome Dr. Jesus Diaz today. Dr. Diaz is trained abroad in nuclear medicine, and he completed his training in diagnostic radiology and body imaging in a fellowship program here at Texas Tech. He's board certified with the American Board of Radiology since 2012. He has provided emergency radiological services since 2013, and he is currently the Radiation Safety Officer for the University Medical Center of El Paso here. He chairs the Radiation Safety Committee and serves as a member of the Patient Safety Council. He serves as a member of the Credentials Committee and the Institutional Review Board for here at Texas Tech. He is also the program director for Diagnostic Radiology Residency, and he serves as on the American Board of Radiology in the Nuclear Radiology Committee. Again, here in El Paso, he serves as the advisor for radiological disaster preparedness with the El Paso Public Health Department. And he is often working in collaboration with emergency medicine on different projects and radiological disaster training. We are very fortunate to have Dr. Diaz with us today, and on behalf of the Southwest Center for Pediatric Environmental Health, I'd like to welcome you. Thank you so much, Dr. Diaz.
Thanks, Dr. Monks, for your kind introduction. I appreciate the invite to talk about these potential exposures and now in the population age. So let me here start sharing my content. Okay, you should be seeing the full screen. Is that right, Dr. Monks?
Yes, sir.
Okay, very good. So I'll start with some acknowledgements, similar to what Dr. Monks mentioned on PASU and the ATSDR. Also, some of this content is available at the CDC, and I incorporated that into my talk. The radiation emergency training site, or also known as REACTS, is one of our sources here and are considered the experts nationwide, located in Tennessee, in Oak Ridge. There is also a website known as Radiological Emergency Medical Management. There's some content from the World Health Organization and also courtesy of Dr. Stephen Boron from prior talks that we have been presented here at Texas Tech in the last few years. So I appreciate those slides given by courtesy. I have nothing to disclose. So our objectives for this talk is to list the sources of ionizing radiation that we may be exposed to or potentially exposed to, the radiation protection measures to mitigate exposures, to identify factors that specifically affect children more and being more susceptible to radiation because of their continuous growth through that period of childhood, and also to name how to decontaminate radiation activity that may be present in our bodies, and a specific management on patients that have been exposed to the radiation and that may potentially be presenting with some effects of that radiation and some syndromes that I'll be talking about. So this is our outline for the next hour. We'll be touching on radiation safety, general principles, why infants and children are more susceptible and what they need more protection. Some triage regarding mass casualty in children, radiation effects in children, how to decontaminate children, and management of acute radiation syndrome when there is excessive radiation, and as a result, the stem cells and other cells of the body are damaged. So some general principles to protect against radiation, and this is universal, both for children and adults, and specifically more in children, as I was mentioning, they're more susceptible. So the time exposed to radiation, that should be minimized. And the distance between the radiation source, if known, that needs to be maximized in order to be protected more from radiation. And radiation will travel many meters, and by increasing the distance from the source, that decreases significantly the intensity of the radiation. And also to place a barrier or a shield between radiation and patients, and that's typically either through medical imaging. We can use lead shields for that in case of radiation incidents or disasters. Building blocks are a source of shielding. Getting inside is a source of shielding as well, and the thicker the building walls are, the better shielding from the radiation. And there is this acronym of ALARA that stands for as low as reasonably achievable, and this is more in the medical imaging setting, meaning that the lowest the radiation that we can use to image children, the better, as long as the diagnostic yield of the images is maintained and does not get degraded by decreasing so much the radiation. Now, so why children are more susceptible? Well, unique physiology, size, weight. They have an increased surface area to volume ratio, and that relates or translates, I should say, into a larger absorptive surface. And so more radiation can be deposited in them compared to an adult. And also, since they're more susceptible to volume losses or fluids, that makes them more susceptible. Since because of the shorter stature, I'm sorry, here it's okay. My motion detector here for lights went off. Since they have a shorter stature, they have a lower breathing zone, and their respiratory rate is higher, so they can absorb or incorporate more radioactive material as they breathe in with a higher rate compared to an adult. Their skin is much thinner, and the epidermis is not as keratinized as adults, so radiation substances can be incorporated at a faster rate compared to an adult. And in cases of the radiation being absorbed and potentially going into the brain, since they have an immature blood-brain barrier, that makes them more susceptible as well. And there are other special considerations in children inherent, when a procedure is performed. The psychological immaturity, that's also an additional factor. And then children picking up things that they find on the floor and other surfaces, they put them at risk of incorporating more radioactive material. And also in cases of radiological accidents, the meal can be contaminated, including the mother's nursing for that child. The milk can also be contaminated with radioactive material, so that's an additional source of radiation exposure. There are some substances, some drugs that actually can help us to remove that radiation that has been incorporated, and they are known as medical countermeasures, and I'll touch on this specifically later on in my talk. The protocols, as you can imagine, based on weight limit for the children, different for adults. And there's a specific recommendations that on this radiation emergency medical management website in the use of these medical countermeasures. And I'll mention briefly, for instance, potassium iodide. This exclusively is utilized in cases where radioactive iodines are released into the environment. And the radioactive iodine will get incorporated through breathing or drinking water source or eating contaminated produce, in the region. And is exclusively for that, the potassium iodide. So will be, I can say, like antagonist or blocker of the radioactive iodine. And there's some other guidelines for when there is improvised nuclear detonations, IND, or what is commonly known as dirty bomb or radiation dispersal device, when a source of radiation is left, as I may be showing in an illustration, on a public place, and people may be exposed inadvertently to that device. So that's the reference for those. There's some clinical decision guidelines as well. Something unique to children is that even though there have been established already thresholds or levels of radiation that can induce acute radiation syndromes or some effect of radiation, including the skin, and I'll touch on those effects of radiation in the skin. Children will present with syndromes or symptoms of radiation at much lower doses than adults. So that's something to be considered. So we should have a, let's say, like a lower threshold to start treatment in patients. There's a guideline here from the FDA that goes back to 2010 regarding counterterrorism measures. And these substances here, along with potassium iodide, DTPA, and Prussian blue, are specific countermeasures to specific radionuclides that may be involved in radiological or radiation disasters. And there's this also references on guidance on how to respond from this website and these references. So in case that there would be a release of radiation, it depends on the amount of radiation that was released. It all depends on actual climate changes, what the weather is like at the time of the release, whether there's rain or not, the speed of wind. That also will be important in determining and establishing safe zones. I'm not going to touch on the safe zones after a release, or let's say a nuclear detonation, or maybe a power plant failure. But that based on the intensity of the radiation, it's how we will respond. If there's minimal release of radiation with the dispersion in the ambient, it will get quite diluted. That may not pose a risk, but it all depends on the intensity. And then, as I mentioned before, given an example of release of radioactive iodines, the radioactive iodines are expected to be present along with one other specific radionuclide, which is cesium, in nuclear reactor failures. So typically, when a nuclear reactor fails, radioactive iodine or iodines and radioactive cesium will be present in the ambient. And they can potentially contaminate the food supply, the water supply as well, the aquifer, and potentially all the produce in that region can be contaminated with radioactive material. So radiation may be in the form of dust, in powder, liquid, or shrapnel in cases of a dirty bomb that may come in contact with hair, skin, clothing, cars, buildings, the streets, sidewalks, your backyard, etc. Everything can potentially be contaminated with radiation. And let me get ahead a little bit on how to decontaminate ourselves. The only way of removing immediately the amount of radiation, and actually that can reduce the radiation to 90%, is by removing clothes. And that will also decrease the exposure time. So by only this simple fact of removing the outer clothes, that will decrease the exposure to radiation significantly. Those clothes will be back and put away from the rest of people in the household or in the area, in the work area or a school or federal buildings. And that will significantly decrease the radiation exposure. So we won't be continuously breathing that contamination that may be in the, the shirt or the sweater or jacket. And in cases of a radiation disaster, we should take shelter. I'll touch on how to contact shelters in our community, or maybe a release from the local authorities that evacuation is possibly better than staying in shelter. If evacuation is not recommended, then people must get inside, stay inside, and stay tuned, radio, TV, or satellite, or social media to local authorities' news regarding when will be safe to come out again, or whether there will be further need of evacuation, whether there'll be further need of going into community reception centers or shelters, etc. So I'll touch on that more specifically later in my talk. There's this triage tool that is on this website, and it's called the Jumpstart Pediatric Multi-Casualty Incident. It's a little bit busy, the slide, but basically, if the child is able to ambulate, it will go to a secondary triage. If it's not able to walk, then we'll focus on whether there is a spontaneous breathing or not. And from there, we'll determine whether the child is at risk of life, a limb, or a function, and potentially death. And that will be place them on the black triage for expectant. And this indicates that the victim is probably unlikely to survive given the severity of injuries. And keep in mind that maybe on a radiation or radiological disaster, there may be physical injuries, trauma injuries. So basically a trauma patient, but with the addition of the radiation, this is known as combined radiation injury when there's trauma involved. Maybe the child may be on the red triage, which is can be helped immediately by intervention and transport, and may require medical attention within minutes in order to increase survival. And also there is the yellow triage color, based on whether the patient is able to withdraw from pain from a stimulus. And then we'll have here the different categories of neurological assessment, whether the patient is alert or responds to verbal stimuli, or only to painful, or actually unresponsive. And this is not, specific for variation. It's just a multiple casualty incident triage tool that can be found in this reference. This is courtesy of Dr. Stephen Boren, a slide from prior presentation. And this is just to give you another example on how to triage people. So those that are stable or unstable, that may be not exposed to radiation, because at that time of the event, maybe the BCER or BCER will obviously have people that are not or were not involved in that area where the radiation disaster occurred. They will go to a clean ED section. Those that are contaminated and stable will go a different route, and splitting women and children and men on different routes, let's say, to medical triage, and determine what would be the next level of care for them. The RSO, which that would be myself, will be involved in determining the levels of contamination on these patients. If the patient is contaminated but unstable, then they will go to a dedicated area that is expected to be already contaminated, because patients being contaminated will be cared for in that area. And there will be also a contaminated holding area as well. Some that are stable and unstable based on their injuries, they go to a RAD triage as well. And that will include, imaging as well. So how we'll be able to detect contamination? There are different ways. This example with the child being surveyed for contamination with a probe or a servometer that detects radiation, It's a photograph from an unfortunate event that occurred in Brazil in 1987, mid-September 1987, where a radiotherapy unit was, the core was actually violated. It was actually left unsupervised, that unit. It was left for disposal, and two adults went into that and basically cracked open the core and extracted large amounts of radiation, which at this point was unknown. But that's how the patient will get surveyed for radiation. And on the right, you can see the pattern of surveying for radiation very closely from the surface of the patient in a zigzag manner in the trunk, and then linearly in the extremities, and zigzag in the face. There's also radiation portals detectors, like in that patient that is being wheeled in. Those are typically the setup for a community reception center, or CRCs, or that are distributed in all the states. Well, I should not say distributed, but they will be ready to be, functional or operational in case there's a disaster. And actually, FEMA has some importance role on that, on determining the shelters. So there's these premises that treating the critical patients based on the trauma level, the severity of injuries, that precedes and supersedes any decontamination procedures. So we should make all attempts to save a limb, function, or the life of a patient, and the decontamination will occur after. Now, let me tell you that it's unlikely for us as first responders, or those in the hospital, secondary or second responders, to be exposed to high levels of radiation. In case of a dirty bomb incident, the amount of radiation gets dispersed in a wide area, and the radioactive material that gets incorporated is so diluted, let's say, because of the explosion. There may be some shrapnel in those that were very near where the detonation occurred, and those may have some a little bit of higher levels, but it will be unlikely for us as first responders to receive a very, very high dose of radiation, as opposed to, let's say, a Chernobyl incident where the first responders, in this case the firemen, received very, very high doses of radiation, and actually they died as a result of the very high exposure. So these are just the statements from the different agencies regarding treating the life-threatening or limb-threatening or function-threatening conditions. And this is more also from to include the American College of Radiology and some of the emergency medicine literature regarding life-threatening conditions, and that the patients can be decontaminated at a later time. So the presence of radiation should not delay the treatment of these patients, and also not delay the imaging studies that the patients may need. And there are ways to try to mitigate the dispersion of contamination through the different departments and the imaging units. So along with that, we need to treat them. There may be thermal injuries as well, trauma, respiratory injury, contaminated wounds. Those wounds that have radioactive shrapnel, those will be disposed with guidance from the radiation safety officer or the radiology people in order to remove that shrapnel and segregate that shrapnel in lead containers in order to mitigate the exposure. All shrapnel should not be attempted to be removed with fingers because the radiation can be very high to the fingers. Those should be removed, the shrapnel, with very long forceps in order to increase the distance from the shrapnel, and that will reduce the radiation exposure to the people in trauma bay or maybe in the OR that are manipulating, open fractures and complex fractures, etc., or removing just debris from the different cavities. They state that surgery should not be delayed, and they recommend this 36-hour time period. We should obtain blood samples for purposes of transfusion, but also for purposes of trending the lymphocyte count, and I'll touch on that. Why is that important? We may consider obtaining chromosomal analysis and looking specifically for chromosomes with 2 centromeres, so dicentric chromosomes. That is a specific marker, let's say, for radiation injury. Unfortunately, those take about 4 days or so to be detected, and we can trend the easier lymphocyte count over following 48 to 72 hours, and with that we can estimate how much of a dose the patient received and whether we should start acute radiation syndrome countermeasures in order to mitigate the results. And I'll that's further down in my talk. This is more regarding supportive care of the patients that will be, regular for anybody that might have been involved in trauma. And specifically to these countermeasures, the blood cells, and specifically the lymphocytes, are the ones that get depleted first, and then followed by the platelets and neutrophils and macrophages and monocytes, and eventually patients then may become anemic, so they will need to be treated for opportunistic infections. So very similar to a neutropenic patient or a patient with potentially with neutropenic fever. And actually, at this point, I'll touch on some referral centers, which let's say that they will be considered like level 1 for radiation disaster, and is the Writing or Radiation Injury Treatment Network. And I'll show a map where the closest network is. Here at UMC, we don't have experience in treating this type of patient, but we can initiate treatment. And if we determine that the dose is high enough for them to present with acute radiation syndrome, we can start with some countermeasures, but we need to notify this network of pretty much his bone marrow transplant and actually umbilical cord transplant centers for them to be the patients to be referred to. Now let me switch gears a little bit and talk about the sources of radiation that we may be exposed to. So the ionizing radiation is defined by that. So it's energy in the electromagnetic spectrum of waves that we may be exposed to, and it is ionizing because as it moves through matter, it knocks off or removes electrons and forms ions. And these ions are harmful, but at low doses, these ions and the energy that is being deposited as a result of these ions going through matter, that harm can be repaired easily. And in the US, the average exposure that we get day and night throughout the year, coming from natural sources, it's this number, 3.1 millisieverts. In addition, now with the wide use of imaging, specifically CT, in in our population for various reasons, and that has increased significantly over the last 40 years or so. We get an additional 3 millisieverts a year. So total, the average is a little bit over 6. But to put this number in perspective, how much is 6 millisieverts? 6 millisieverts may be about a CT of the abdomen and pelvis, just a single CT, or also about a single CT of the chest. That's as much as we get on average here in the United States. This is a table from the National Council of Radiation Protection from 2006. I'm not aware if this has been revised, but pretty much all the recent literature refers to it. And this is on the top what we get from naturally from Earth. So we get radon and thoron. These two isotopes come out the ground. And actually, the recommendation of ventilating the basements is because of this. The basements of buildings and residential basements, all basements accumulate radon and thoron. And there's a specific, specifications in building construction of basements in order for these to have ventilation, in order to get this radon and thoron from not accumulating within the basement. And then we get other terrestrial sources. Food has a little bit of radiation, specifically potassium 40. So all meals, all water sources have a little bit of potassium. Our bones incorporate that potassium, and actually by sleeping next to our partner or sleep in a household, we get a little bit of internal potassium exposure from siblings or significant other spouses, etc., which will be the internal. And some come from the cosmic X-rays. And then we have a little bit of consumer products. And what are these consumer products? Nowadays, with many consumer products being digital and not analog, like watches and clocks, the radiation exposure is much less. But in the past, old watches and clocks, the needles will have that glowing greenish, fluorescent or actually phosphorescent effect is from radium that will be radioactive radium in the dials of the watches. Currently, the smoke detectors have a source of radiation, specifically americium-241. So that's a source of radiation. It's very little, but it's there. The tanning, the sun tanning lamps with the UV light, that has a little bit of radiation. Some glassware will have a little bit of radiation, and also the exit signs in all buildings have a little bit of source of radiation in the form of tritium, which is hydrogen 3 or 3 hydrogen that has a little bit of radiation. All the medical exposure from medical imaging comes from CT, almost like 50%. And you can see the increase from 1980 to 2006 of how much the radiation has been increasing from the widespread use of CT. These are the different levels of radiation that the different studies deliver. So you can expect that very low from a forearm or elbow radiograph, as opposed to a barium enema or an upper GI, for instance. And then more examples from a CT dose of radiation as well. Actually, a coronary angiogram delivers quite high radiation. So a CT coronary angiography is one of the highest radiation levels of imaging studies that we can be performing in our patients. And then other studies, and you can imagine a coronary angioplasty also that delivers a significant amount of radiation. that actually the International Atomic Energy has a repository of radiation injuries from cath lab that have occurred over time, and this is from nuclear medicine. Cardiac stress studies also deliver a high radiation, but none of these have been involved in radiation injury. Now, to put this again in perspective, in terms of how many chest radiographs, or the background that I was saying, the normal background radiation that we get, specifically Colorado has higher amounts of background in the nature or in the United States. So for instance, as I was saying, about a CT scan of the abdomen delivers about 2.5 years of radiation, and it can be up to 3 years worth of radiation. This compares to 360 flights from New York to Seattle compared to a CT of the abdomen, and a CT of the abdomen and pelvis is about 100 chest radiographs, so you can have an idea of how much radiation are those studies. This is a table that specifically I'd like to draw your attention to this here on the left of the slide, that shows the highest risk of that are the children to exposure of radiation, and how this graph falls as we age after 40, 50 years old, and eventually once we are or become elderly, the risk of presenting radiation effects in terms of actual cancer or developing carcinomas after exposure to excessive use of radiation in medical imaging can occur. So it typically will take like maybe 50 or more CTs of the abdomen to a person or a patient or even a child for the threshold of reaching that threshold that potentially the patient may develop a carcinoma. However, the carcinoma may develop in about 20 or 30 years from the exposure, so it's not immediate, although leukemias can occur maybe as early as 3 years after exposure. Now, in terms of comparing these adult doses that I was showing you to pediatric doses, and what is the actual effect of radiation, the child may get effects to radiation maybe at doses that are about a third or so from an adult. So we can say roughly that children are more susceptible like 3 times more than a normal adult, and that's a rough estimate. Now, other sources of ionizing radiation that we can be exposed to come from these. Nuclear blast, I already mentioned the dirty bomb. I mentioned the unfortunate Brazil incident because of medical radiation therapy equipment left unsecured. There have also been accidents that was in Peru at about close to that same year, I think it's 89, that industrial radiography equipment was left also unsupervised, and that resulted in radiation injury. These are the isotopes that we may encounter. As I mentioned here on the top, americium has the smoke detectors. The cesium, when there's a fallout from nuclear reactor, the radioactive iodine. We have radioactive iodine in nuclear medicine departments, that is for the treatment of Graves' disease and thyroid carcinoma, and obviously sources from plutonium, uranium, And let me mention something to you regarding the power plants that we have here in the United States. These are designed to not have excessive amounts of uranium. So basically, if there's a power plant failure of any kind, there will not be a nuclear reaction because the uranium used there is not enriched. There's a specific percentage. So let's say that is low in enriched uranium, so it will not detonate a nuclear reaction or reach criticality for a nuclear reaction to occur. So these are very, very safe facilities. So the release of radioactive material is expected to be minimal based on that. Recently, there is these two isotopes in the bottom of the chart, of this table, sorry, that lutetium-177 currently being used for the treatment of neuroendocrine tumors and prostate carcinoma, and yttrium-90 that is used for liver tumors or also neuroendocrine tumors as well. And this is used through interventional radiology, delivering the radiation through a microcatheter in the liver. Our closest nuclear reactor, which is a power plant, it's in Palo Verde in Arizona. That's 50 miles west from Phoenix. So that's several hundred miles away. And then the other two that are relatively close will be in Comanche Peak, that is southwest from Fort Worth, and then 90 miles southwest from Houston, we have the South Texas nuclear reactor, and these are known as commercial nuclear power reactors. Now, going back to the imaging of children, there is this campaign of Image Gently, where we adjust the doses based on the size of the children. And also there's a consensus regarding administering radionuclides for nuclear medicine studies as well. And we have an Image Wisely campaign that's to appropriately scan adult patients and potentially pregnant patients as well, adjusting the doses of radiation. And let me tell you at this point that if a pregnant patient receives less than 100 millisieverts during a medical study, which is typically much, much less than that, as you can see the CT on the prior slide, a CT of the abdomen and pelvis delivers only 10 millisieverts. So we're talking about a female receiving over 10 CTs of the abdomen and pelvis. That's when the risk to the conceptus of the fetus reaches the point of maybe an abortion may occur, or even an abortion may be recommended, but that would be a very, very rare scenario. And this is just some statement from this Image Wisely campaign regarding the risk and the benefit of doing a radiation or not. The American Association of Physicists of Medicine now, back in 2019, now recommends against shielding the gonads or the breast of patient, because actually that increases the radiation dose to the patient. But we still at UMC, for cultural reasons, we still give the option of parents whether they like to shield their children gonads or not, based on this. But this is still widespread use throughout the United States and culturally appropriate if they like to shield the gonads or breasts. This is a statement from the actual OBGYN literature from the ACOG that it's unlikely that there will be any fetal risk from radiation to excessive radiation from medical imaging to a pregnant patient. So now, this is a very important fact. What's the difference between exposure or contamination? So radiation exposure is like when you have a CT of the chest or a radiograph, and the patient is not contaminated. The patient was just exposed to radiation, so the radiation already interacted through the patient's chest and lungs and bones and vertebrae and lung and heart, as opposed to contamination when the actual radioactive material gets deposited in clothing, skin, and hair. And that could be internal contamination. That's when it's inhaled or ingested, or maybe through an open wound and then goes into the bloodstream. So those are very important facts to know the difference between radiological exposure and contamination. And I mentioned to you already that by removing clothes, that removes about 90% of the radiation. In cases when there is a contamination to the clothing or to the skin, the decontamination procedures should aim to at least decrease the exposure in the skin to 2 times background. And the background will be detected with a sorbimeter before taking care of a patient. So as we approach a patient that is contaminated, we check how much, because we're currently exposed to some degree of background radiation. So the aim is to at least do these decontamination procedures and take the reading of radiation to at least 2 times the background. Showering is an important decontamination maneuver, and ideally it needs to be done with warm water, and that it's called tepid water. The tepid water is 2 parts of cold water and 1 part of boiling water mixed, and that is about not as lukewarm, a little bit lower than that, and then soap. That's the best way to decontaminate. Either that can be done manually or through a shower. It is important to not use any type of hair conditioner if we're using shampoo to decontaminate the hair of patients, because the conditioners in the shampoo products actually will bind the radioactive material to the hair, and then it won't be able to remove that. And it's also important to keep the running off water from the from the hair or face and neck, so as not to get that running off water into the nostrils or to the mouth. And also it's important to know that children can undergo hypothermia more rapidly than adults, so that's important. Now in areas where there's water deficiency or there's no shower available, commercial conventional wipes will be a way to decontaminate. And this is from the CDC on how to decontaminate ourselves and helping others by removing clothing, hand washing, hair washing. And there's here an example on how to decontaminate children very roughly. The same procedure as we would with adults, and even for pets. So specifically for children, they may be frightened from the situation, so the contamination may take longer. There's videos and resources available in this website to go over decontamination specifically for children. It's important not to rub the skin too much, because as we rub the skin, actually we can potentially induce more absorption of the isotope. So it's a gently rubbing of the skin surfaces. This will apply also for adults, but remember, since children have a thinner epidermis and the stratum corneum of the skin is less keratinized, then children will incorporate the material more rapidly. So that's important to know, as opposed to chemical, where rigorous skin rubbing is recommended. This is not for cases of radiation. The water pressure is an issue for children. The hypothermia, as I mentioned, and obviously, some mental health concerns that are present in children. Now I'm going to move over to the health effects that radiation can occur, and these are the effects that we can expect from excessive radiation, going from temporal sterility to the reduced production of blood cells. It can go into permanent sterility, hair loss, and erythema. And these are the thresholds that these occur. And just to keep in mind that, again, these may occur with lower doses in children. So now moving to the acute radiation syndrome, which is also known as radiation toxicity or radiation sickness, is the effect of the depletion of immature cells, mostly bone marrow and also the GI tract. It takes about this amount of radiation, 70 rads, to present with this. This is a very, very, very high amount of radiation. It's hundreds of CTs or even more. And for this to occur, the whole body or most of the whole body must be exposed to. The radiation must be penetrating. So in the form of gamma radiation or neutrons. Alpha radiation, which it's a form of radiation that actually can be stopped even with a sheet of paper, that travels very little. So the danger from alpha radiation is if it gets ingested or inhaled, then it comes in contact, bloodstream and lining of the GI tract and respiratory tract, and that can occur and result in acute radiation syndrome. So the actual acute radiation syndrome occurs when very high levels of gamma radiation, like a nuclear detonation or the Chernobyl incident. These are the different symptoms that can occur if it affects the bone marrow or the GI tract. And also of note is that the brain is very radio resistant, so radiation resistant. So the last organ to be affected by excessive amount of radiation is the brain, but when that occurs, pretty much the patient has no chances of surviving. And I'll go over these syndromes where there occurs some nausea, some vomiting. Eventually, the lymphocyte counts will decrease, and about 50% of the individuals that may expose to this level of radiation will die in about 2 months, even with the best care possible. So this is also a matter of probabilistic injury if a certain number of patients get involved in this. The GI syndrome is, nausea, vomiting, diarrhea, and 100% of the patients can die from this, depending on how high the dose. But deaths can occur within 2 weeks in the worst case scenarios. Unfortunately, if a patient after an exposure presents with nausea, we cannot really tell whether it's psychogenic. So we will need, help from ancillary studies like following the lymphocyte count. And this is the cardiovascular or CNS syndrome, where if there's altered mental status, seizures after that, that is an ominous sign, and actually no recovery is expected. The cutaneous radiation syndrome is the erythema that occurs. Characteristically, it's itching, but it's not painful as opposed to a thermal injury. And this can progress to even necrosis. There's a tool to kind of estimate radiation exposure internally that can be found in this website, and there's some iPhone and iPad available for this. This is the treatment that these patients will receive roughly based on the amount of radiation. So there's supportive care as any other patient, and then here we go into antibiotics. because of the bone marrow depletion, the colony stimulating factors will be a need for this. These patients will need to be placed in reverse isolation. Gut bacterial prophylaxis, consider bone marrow transplant, and if this amount of radiation is received greater than 8 grays, that probably, even with all the best standard of care, the patient will not survive. Now, specifically to countermeasures, and I'll move quick so we can go over these all slides. These isotopes can be decorporated from the body with these specific countermeasures. And I'll touch on specifically DTPA, potassium iodide, and Prussian blue. There's an online calculator that, depending on the onset of vomiting, we can estimate how much radiation the patient was exposed to. So if vomiting occurs within a matter of minutes, as you can see here, 5 minutes, that estimates that the amount of radiation that the patient received is 35 grays. And actually, this is very unlikely for the patient to recover. This is for the lymphocyte count trending. And based on how that decreases over a day or two, we can also estimate the amount of radiation. So for a patient that received about this much of radiation with these trending lymphocytes after 2 days, let's say that is about 1,000, then the patient will definitely present with the hematopoietic syndrome and needs to be started immediately on these granulocyte colony stimulating factors. This is a table in case that Andrew's curves of lymphocyte depletion are not available. This is available online and it can be calculated. This is specifically for the colony stimulation factors based on the triage of patients and the dose received. And this is regarding, based on the combined radiation injury, when there's that, and also burn to the skin, another reference for that. So going to the management, I'll jump to these colony stimulating factors of filgrastim. And that's the dose for a child, 10 micrograms per kilogram per day, until we see some signs of recovery. This is applied subcutaneously. There is a pegylated form that is given as 6 milligrams, and then a week later, PRN. This other product, there are some side effects from that. At these doses, based on kilograms of the child, and also until we see some recovery. These specifically targets the platelets, romiplastim. This is given once, 10 micrograms. Sub-Q as well. Once we know that the exposure is about 2 grays or even before, because remember, children may present with the syndrome at lower doses. And also specifically for these types of isotopes, when we know that plutonium was involved in the radiological exposure, or americium or curium, DTPA will chelate these from the body, and this is given by an infusion. And also there is at a dose of 1 gram for children above the age of 12, and 14 milligrams per kilogram for those under the age of 12. There's also a nebulization form or inhaler through a nebulizer that can be given, but this has not been tested in children. For adults, it's okay, but this has not been tested in children, the inhale or nebulizer form. Zinc DTPA is another option, also for the same isotopes. Is the preferred initial therapy in pregnant patients. The caveat with calcium DTPA is that it will deplete magnesium and zinc. So there's going to be some zinc supplement. And let me move on as I'm getting here at the top of the hour. On the Prussian blue, this is specifically for cesium and thallium. And this is given by mouth at that dose for adolescents, and for peds between the age of 2 and 12. This is given by 1 gram 3 times per day. And the duration of treatment is based on calculation whether how much isotope has been decorporated or excreted. It's not absorbed through the gut. It will be excreted, it will just be binding the cesium and the thallium. And then lastly, the potassium iodide, which specifically will be for when there's release of radioactive iodine. And the sooner this potassium iodide is given, within 3 to 6 hours is ideal. It will block any radioactive iodine from being incorporated. Some advocate up to 12 hours, and there will be some radiation protective effect. But ideally, the window is the window within 3 or 6 hours after knowing that there's release in the ambient. There's some contraindications. There's some side effects to it. This is a table with the recommended doses based on the age. The potassium iodide is available in tablets and oral solution. And actually, if there is no oral solution available, the tablets can be crushed and put in milk, orange juice, chocolate, coffee, etc., and it can last about a week, but it has to be refrigerated between 2 and 8. Let me tell you that in these nuclear reactors, the people living close by and on the map that I show you, the population around 10 miles should have, and this is like a federal initiative, they have available potassium iodide readily available in case there is a release. The potassium iodide can be found on these websites in the different pharmacies in the United States. And there is a national strategic stockpile that stocks these and other like the TPA and Prussian blue, but it takes a few days for those to arrive to the area. And in case there's need for potassium iodide for the population to take, that will be initiated or be instructed by the local authorities. So I think I'm going to stop at this point, letting you know that there's available resources at the CDC in order to respond this app that is available for iPhone and Android. And then if we were to need expertise or consult, they are available 24/7. This is the Oak Ridge people in Tennessee. And the network of hospitals that I mentioned to you, where there is people, specifically with highly trained for taking care of these patients throughout the United States through the Radiation Injury Treatment Network. Our closest is in Banner in Arizona. These other areas that have a 2 on it, like here in, it's Texas Children's, so they specifically take care of children in addition to patients with combined injury with burns. And I think at this point I'll stop. Dr. Monk, sorry I went over a little bit, but there was a lot of material to cover, and I'll take any questions.
Dr. Diaz, Dr. Watkins is asking if you could explain the GI bacterial prophylaxis.
Oh, okay. I don't have the specifics for that. Unfortunately, I didn't review that. But the microbial prophylaxis is to avoid obviously the migration of microorganisms from the gut into the bloodstream, because as a result of radiation injury, I will need to check on the protocol, but I'm thinking, and this is a educated guess, that will include something like neomycin or some agent to decrease the proliferation of bacteria. So then these patients won't get septicemia as a result of the migration from the disrupted mucosal lining in the gut. And I apologize, but I can look into that and get back to her. But this is what is the recommendation on these patients.
Thank you so much, Dr. Diaz, for your presentation.
I was seeing Dr. Watkins' comment. Yeah, something similar to the SVP prophylaxis that we do for cirrhosis, but I didn't look into that, but I'll check on that. I think it's a quite relevant question, because the reverse precautions, we follow that for neutropenic fever on a daily basis, let's say, but I don't have that specific data and protocol for the gut prophylaxis. Thank you.
Okay.
Let me see, is there any other option? Are there other questions in the chat?
I do not see any, but
Okay.
if anyone would like to email me their questions, I can get those to Dr. Diaz. And again, thank you so much for attending, and thank you, Dr. Diaz, for presenting today.
You're most welcome.
And,
thanks for the opportunity.
wonderful week, everyone. Thank you.
Okay, bye-bye. Have a nice day.